Good morning, everyone. My name is Ryan Williamson, and today we're going to talk about the issue of family presence during cardiopulmonary resuscitation events. Our case in particular was a 45-year-old female who came to our emergency department with complaints of left lower leg pain, constant chest pain exacerbated by breathing, shortness of breath, tachypnea, and difficulty speaking. Her vital signs showed an elevated heart rate of 120 beats per minute, blood pressure that was low at 90/49, and a O2 saturation of 82%, which is well below the standard norm of 95 to 99%. Physical exam showed a left lower leg edema that was tender to palpation. Labs came back showing respiratory alkalosis, hypoxemia, elevated troponin 1, and brain natriuretic peptide. EKG and imaging orders were placed, showing a right bundle block, while the CT angiogram showed evidence of bilateral pulmonary emboli. The echocardiogram showed right ventricular dysfunction. All this evidence together pointed to the diagnosis of deep vein thrombosis with bilateral pulmonary embolism. We ordered thrombolytic therapy for our patient, but before we could administer it, she entered asystolic arrest. Resuscitation efforts were made, but unfortunately there was no return of spontaneous circulation. Now, it was during this time one of our staff members asked the question, should the family be allowed to stay? Now, in this moment, there's not enough time to have this conversation. Family was asked to leave, as I claimed it was important, and we carried on in our resuscitation efforts. Before we talk about that after the question, we're going to do a little bit background on the medicine at play. A deep vein thrombosis is a blood clot in the deep veins of the lower leg. This typically occurs in the valve pockets of the veins, and it causes an increase in transcapillary pressure, so increases fluid pressure. That's going to cause leaking of fluid into the leg. Now, that edema is going to subsequently activate pain receptors, causing tenderness to palpation in that area. The pulmonary embolism is when a clot translocates to a pulmonary artery. So typically, that's that deep vein thrombosis we talked about, dislocates from the vein and moves up the circulatory system to the pulmonary artery and gets lodged there. Now, this is going to cause a litany of other symptoms we saw, from the increased heart rate, the decreased blood pressure, the decreased oxygen saturation. The right ventricle is working against this pressure buildup, and unfortunately it beats so much, eventually you typically see right ventricular failure. The treatment includes thrombolytics, like the low molecular weight heparin. These are simply designed to try to break up the clot. Now, 79% of patients with pulmonary embolism have evidence of deep vein thrombosis. There's over 100,000 cases annually of pulmonary embolism, and about 25% lead to sudden death. So this is a very serious medical issue. We'll talk briefly just about proper CPR and its implementation. About 60 years ago, cardiopulmonary resuscitation was first introduced, and it showed significant increases in survivability for patients that are undergoing cardiac arrest. Of patients who performed adequate CPR, 48.5% achieved a return of spontaneous circulation, but out of that percentage, only 15.4% survived discharge. The compressions are often delivered at rates lower than recommended in the hospital setting, so this is evidence for a need to continue education for hospital staff. Now, back to our issue at hand. Our team member asked if the family should stay, and this isn't just not the time to deal with it in that moment. However, evidence does show that family members involved during this process do not get in the way. In 1987, there was a study that had several family members stay with the support staff present during this resuscitation event. Those family members were surveyed after, and 94% said they would do it again. 76% said that it adjusted better to familial death, and 64% thought it was beneficial to the patient. Most importantly, there was no evidence that this interrupted the resuscitation effort at all. Now, that's all well and good, but asking how the medical team feels about this is just as important. One study of 164 nurses showed that barriers to this included performance anxiety and fear of lawsuits, as well as fear of the patient getting in the way. So it is clear now that the medical community is not entirely on board with this. However, the same group of nurses did see some benefits, that the family would see that everything was done. There'd be less chance of them getting upset in that regard. So it's kind of a mixed bag on this in regards to how the medical community feels about it. Now, there's no formal laws about this in the state of Colorado. They tend to defer to the state of advanced directives. Advanced directives are just instructions that guide healthcare decision-making in accordance with the patient's wishes. So patient fills this out before they hopefully fill this out before they go into an incident of cardiac arrest. This gives caregivers an idea of whether they want to be resuscitated or not. However, it doesn't have any mention of family presence. So if you're going to want to move forward, you need to add this to advanced directives. Now, the American Association of Critical Care Nurses and the American Heart Association both agree that families should be given the option to stay if they have a support staff present and they're prepared for this. Now, they emphasize the need of a written practice document that outlines proper protocol and staffing and how this is going to take place. But one recent survey showed that only 5% of EDs have this document and protocol written. Also, they both claim that if family member is disrupted, they are asked to leave. Therefore, it is a privilege and not a right, and they need to ensure patient safety overall. For us to move forward in this issue, we need to implement proper written protocol on this. I stand by my decision in this case to ask the family to leave because we had no proper protocol from a hospital standpoint, and it was not the time to have this discussion when we're trying to save our patient's life. However, I do see the benefit of having family members staying during resuscitation events. If we're going to do this, hospital executives need to implement proper protocol. It needs to be in written format so everyone can follow it. We need to have training for our staff, including education modules of why this is important. A lot of our staff will probably push back on this idea, so you need to educate them so they can see the evidence I just showed you. This can be the form of modules or however you like. Finally, I recommend addending this directive to the advanced directive for the patient so that we are making sure that we're not overstepping the patient's desires. The patient has the right to waive them, and this is going to make sure that we're providing the best care and quality of care to our patients. This is where I'd ask you guys if we have any questions, but we're submitting this online, so I'll take that as a no. I want to thank you so much for your time today, and here are my references. Beautiful. All right, everyone, thank you again, and good luck on finals. Take care.